a Q&A time towards the end, which Laura Bingham from Innovista will help facilitate. But don't worry about waiting until then to ask your question. Go ahead and ask your questions at any time, and we're going to get to as many of those as we possibly can during the session today. If we can't get to your question, we will make sure someone will follow up with you via email with an answer afterwards. And then lastly, today's session is being recorded. So what's going to happen is after the show or the presentation, I'm going to send everyone this afternoon or this evening at the latest a link to the recording and also where you can download the slides. And so that will go out to everyone. So even if you have to drop out early for some reason, don't worry, you'll be able to catch up on the whole thing. And we hope that you review it later and share it with colleagues, etc. So without further ado, I wanted to introduce very briefly our presenters today. Pam Audish, who is the Vice President of Medical Management with Innovista, and then Dr. Gary Weiner, who's the Chief Medical Officer, and Garrett Griffith, Senior Program Manager, all from Innovista. And then again, Laura Bingham is with us, and she's going to be helping us with Q&A. So I'm going to go ahead and turn it over to Dr. Weiner at this time. So welcome, all of you.
Thank you, Garrett, and thank you all for the opportunity to speak today. Pam, could you advance it? So today we really want to talk about 5 things. We'll talk a little bit about what Innovista is. We'll talk about what we believe the future holds, and then specifically drill down into our SDOH programs that we've developed for part of our Texas market in Medicaid, and then some of the programs we're building for commercial diabetic population, and then lastly, some of the successes and challenges of reporting. Next slide, please. So Innovista is a wholly owned subsidiary of HCSC. We're located in the far western suburbs of Chicago. We were originally created to take on management of multiple medical groups who contract with Blue Cross for HMO business, and we were also contracted to take on business where we can joint venture with physicians to move them from fee-for-service to risk kinds of products. We began operating in 2014, and we are fully certified MSO for both Blue Cross of Illinois and Humana. Next slide, please. Even though we are a wholly owned sub of HCSC, we are payer agnostic. You can see by this slide that across our markets, we deal with 21 different payers. That number is probably climbing and as of today. To give you some additional context around Innovista, we have 2 main markets, one in Illinois and one in Texas. In Texas, we have 3 sub-markets, one in Dallas, one in Houston, and one in San Antonio and the Valley. In Illinois, we have a market that's primarily in Chicago, and our work there covers the spectrum from managed HMO business all the way to fee-for-service shared savings in Texas. Next slide, please. So this is really our goal, is to move physician and physician groups from the fee-for-service model, which we all pretty much live in today, through pay-for-performance and eventually over to risk arrangements. We do this with underpinnings of our financial management team and tools, as well as our IT infrastructure, data management, and reporting. In doing this, we really are there to guide, help, hold hands of physician and physician groups as they move along this continuum. We are not at one particular point as an organization, depending upon the market, depending upon the physician group. We could be in all the way over to the left, and in the same physician group may also have a risk arrangement. So we have the capabilities and really the strategies to help people in all of these, although ultimately want to move people over to that risk side. Next slide, please. So now comes the crystal ball. Next slide. Really trying to understand for physicians, especially that rapidly vanishing group of independent physicians, what they're going to be facing in the next couple of years. Clearly, there's consistent recruitment pressure. Physicians are continually battling against payers and other organizations for physicians coming out of training or physicians looking to transition. In that, we have a large cohort of physicians who are aging and who are looking for retirement. We all know about the administrative burden that we've experienced, both because of payer requirements and certainly EMR requirements. Most of our physicians have experienced some loss of control around relationships with payers and consolidation with larger groups. The rates that are being paid are not keeping up with inflation and certainly with office expenses. And then ultimately the legislative environment, which sets the framework for how policy then controls both implementation and reimbursement. Next slide, please. At Innovista, we firmly believe in transitioning people from primary care 1.0 to primary care 2.0. When you look at that prior slide of transitioning from fee-for-service to fee-for-value and risk-based products, you can't do it successfully under primary care 1.0. And so we work with physicians and physician groups to really move into team-based care, to really have folks practice at the top of their license, be able to be able to move people into that risk space. And ultimately, what we're beginning to see is as we help take the administrative and non-clinical burden off of physicians, that both their productivity goes up, but also more importantly, physician satisfaction has started to increase. Next slide, please. When you look at the data that's been collected around physician burnout, the challenges that I just identified are highly validated here. So when you look at burnout issues that physicians relate to, administrative burden, long work hours, and EHRs are the top three. And while we can't necessarily do anything about the EHR and long work hours, one of the things that we do help with is bringing administrative controls to the practice and working with payers in reducing that administrative burden. We also believe strongly that by moving to team-based care, that will also reduce the administrative burden and paperwork. But the challenges that physicians face in the present fee-for-service environment are significant. Next slide, please. And so in the context of this, we now have, or I should say, we have an increasing awareness of social determinants of health. This is not new for anybody. I graduated my residency in 1982, and as a medical student in the late 70s, I recognized that social determinants were a large part of both admissions, readmissions, and emergency room use. One patient who continually comes to mind was a patient who had heart failure and diabetes. We would tune her up in the hospital, and we would send her home. But we never knew that she lived in a 4-story walk-up. She had no air conditioning, and she had no way to get to the pharmacy when she got home. So within a couple of 3 weeks, when her meds ran out, what do you think would happen? She'd be back at the hospital. Those kinds of issues are now becoming front and center, in that we certainly are focusing on them. We also know that social determinants account for a significant amount of healthcare costs and healthcare morbidity. And we also know that much of this is actually remediable with a partnership with community resources. Next slide, please. So layered on top of those prior 2 slides of all of the challenges and all of the obstacles that physicians face, we now have extra added issues of both collecting information about social determinants, developing interventions for those social determinants, and then ultimately following up on those social determinants. And this is a slide that really talks to the fact that while physicians understand the importance of these SDOHs, their ability to assess them accurately, the ability to navigate successfully to community-based organizations is extremely limited. And so today we're going to talk a little bit about one of our successful programs, both in Dallas and an emerging one for Medicaid and an emerging one for commercial patients that is beginning to help and augment and address these specific issues for our physicians. Next slide, please. Needless to say, social determinants really are a wide variety of non-medical issues that impact healthcare. We talked a little bit about them, but these are 8 of them. Certainly housing instability, food insecurity, transportation, education, employment, family and social support, interpersonal violence, and utility needs. There are some of these that we can impact. There's some that we can't. We also know that taking a history about family violence or violence in their environment is significant because that violence and that impact lingers on generation through generation, especially adversely affecting children. Next slide. So again, this is just a reiteration of that prior slide. Physicians have very little time to add on to their already busy day to either assess or address these issues. Next slide, please. Primary care docs are significantly more likely than specialists to report these resources being impactful. Some of that is obvious. Primary care physicians would be more linked in and more attuned to the patient's environment, the patient's family, et cetera, et cetera. Investing in a community capacity is huge, but again, becomes difficult around connecting those appropriate resources with the patient. There's other investments that can be made in technology and human capacity, but probably most importantly on the physician side is screening those patients to identify which SDOHs exist in the first place. Next slide. So what we did in Dallas is we created a SDOH program through using community health workers. I just realized that we used a lot of abbreviations and acronyms here we should have identified, but CHW is community healthcare workers. If you're not familiar with community healthcare workers, they are actually trained individuals, non-medical, who live in the community, who will do things like help monitor blood pressure, help monitor dietary compliance, help with transportation, be a liaison between the patient, the family, and the physician or the clinical site. This has been particularly impactful in our success in Medicaid. The Hispanic Health Council has really called out CHW as a way to help address SDOH. There needs to be adequate funding. You have to be careful of caseloads. Recruitment, like everything else that's going on right now, has been difficult. There are emerging and emerged training centers for community healthcare workers. They have to be supervised and integrated into the healthcare team, and then ultimately outcomes need to be monitored with evaluation. Next slide, please. So what we've really decided to do is develop an incremental approach to social determinants. And that approach is consistent with how NCQA and other health plans are beginning to move. They are in the early stages of identifying related processes and outcome measures and requiring standardized screening tools. At Innovista, we are beginning to cull data through claims. There are some challenges with that, and we'll talk about that later. And in our particular arrangement with the one payer in Dallas, we are actually being paid for performance. So we've sort of leapfrogged this stepwise process. But we firmly believe in, just like with any other value-based product, in building this over time so that patients, physicians, the system can accommodate to the transition. Next slide, please. So I'd like to introduce my colleague, Garrett Griffith, who's been the program manager for the Medicaid SDOH program. Garrett, over to you.
Thanks, Gary. So we'll actually get the chance to look at the application of some of what Dr. Weiner was just going through, some of the research, and a little bit of background on this program. We were able to partner with an insurer who was motivated to get into value-based Medicaid in 2019. And over the past 3 years, we've been able to grow our attributed population to over 50,000 lives. And we obviously see a huge deficit, specifically in the social determinants of health realm, for this population. So I'm going to go into some of the ways that we try to bridge that gap in the next slide. Thanks. So I think this slide speaks specifically to some of the key initiatives that we've done, kind of our playbook, but also touches back into some of the things that Dr. Weiner had mentioned of investing in technology, in human resources, as well as investing in the community. So I'll touch briefly on how those support that. But with such a large population, we've obviously had to try to prioritize those with the greatest social determinants of health need. And a way that we've done that is through investing in predictive analytics. The vendor that we've worked with helped us to build 3 different models: the emergency department frequent flyers, behavioral health intensity impact, and low continuity of care. And those 3 models they ingest publicly available data that takes into account food deserts, transportation needs, and geographic needs data. It takes claims as well as assessments we complete, and then basically churns out a suggested, I guess, risk probability of who our staff should be connecting with. And historically, our CHWs, or our community health workers, have used the, they'll go through that to identify them, but historically they've used the health leads SDOH assessment. It's an assessment with 8 questions asking simply and at I think it's a 4th grade reading level, trying to identify if they have housing needs, food needs. So it's one of the available assessments. Due to the greater national recognition, we are actually working on shifting over to the CMS Prepare assessment. But so everything that we talk about today has been using the health leads assessment. The CHWs are trained, as it says on the slides, to try to build relationships with people. This is a population where there's a lot of mistrust, feeling like no one's really on their side, and not due to the, anything specific from the PCPs, but there's just a lot of unknowns for them. And so the CHWs are trained to build trust and to try to connect with them and to identify what needs they have, specifically expanding upon and looking into maybe the unspoken parts of what someone is saying when they meet with them. As an important part of that, the CHWs from the assessment then will go into community-based organization referrals. So we call those CBOs. But after a need's been identified, we utilize another technology platform called Find Help. There is a free version of Find Help. It used to be called Aunt Bertha, for those who might be familiar with that name. But essentially, it's a database where you're able to find, it's categorized by needs, and you're able to find based on what needs a patient might have, which organizations they might be able to connect them to. We do utilize the professional tier just because that helps give us extra data, gives us better insight into searches, referrals, and referrals completed. And we'll show a little bit of that data later on. As another part of investing in the community, we actually have built, or we worked on building a CBO collaborative. And so we actually partner with multiple different kinds of CBOs where we meet about once a month to discuss needs that we've seen in the community, how we might be able to help bridge some of those needs. And I think that a perfect example of this was especially during the beginning of the pandemic, when there were a lot of different needs, a lot of unknowns. This organization helped figure out how we could help the Medicaid population get tested for COVID or get treated, and then eventually help them get vaccines and information and help overcome some of maybe the misinformation that floated around as well. And finally, obviously, one of our foci is on supporting PCPs, and we hope and try to bring reprieve to PCPs by putting together education and collateral to address quality gap coding, as well as keeping them informed on CHW connections to patients. And I do just want to also touch on that our model that we use here is very focused on social determinants of health, and part of that reason is, and we won't touch on any care management, is because that is done on the payer side or by the insurer. So we do just focus on meeting social determinants of health needs. Next slide, please. This goes into a little more detail on the CHW workflow that I was just mentioning. So some of the things that go into how someone's identified, we have the predictive analytics. We also can get PCP referrals. There could be self-referrals because we do advertise in the offices. And then as well as if there are quality gaps that we need to reach out for, or just if there's a CHW embedded in an office, if they're in a PCP's office, sometimes they, then patients are able to get into the system that way. And then, of course, touching it again on the screening that happens and then the outcomes that we try to have with follow-up. Next slide, please. So now going into some of the statistics that we have, this is a slide that is looking at, so the 100% is just out of all of those that we contact, all the patients that we touch, that's 100%. Obviously, if we talk to them, that's the number there. And then the dark blue bar on the left represents how many times we're able to connect with each patient. And we have seen that decline slightly, and that is something that we are trying to work on. But it's, I guess, something that we're looking into, is that even though the number of connections has declined, we've actually seen an increase. On that far right bar is the percentage of those that we contact with, how many are willing to complete a full health leads assessment, that SDOH assessment. So we've seen an increase in that, and then a decrease in the amount of times we've had to connect. So in some senses that can be good, because we've had to connect less in order to complete the assessment. But we would like to see that eventually increase, because it does also speak to the ability we have to follow up, and how many times we're able to connect and learn about whether they actually receive the help they need. And I'll touch on that in a few slides as well. If you go to the next slide, thank you. So this slide is looking at a comparison of, we took the different, there are obviously more SDOH needs that are out there, but we took the top 5 from each year, 2020 and 2021. And something that we've seen overwhelmingly, and I apologize that the colors don't match up, but it is actually that housing needs are overwhelmingly been the greatest need. Whether housing instability, whether they're just worried about it, or they're homeless, or they're not sure how they're going to pay rent. That is a constant fear and need that we've seen in the population, followed by food, and then health, education, health access. So it actually was almost identical in each year, with the exception of goods. We saw in 2020 that there was a huge need for goods, which was in this case was actually a huge need for diapers. So we were actually able to partner with our CBO collaboration and do diaper drives, and we did multiple diaper drives, and with the CBOs that we partner with, as well as the PCP offices, and we still continue to actually provide that. So that might be one reason why it dropped in 2020 from being in the top 5 needs, because we have partnered with organizations that continue to provide and fill that need. Next slide, please. So this is looking at the CBO referrals and gap closures in Find Help. So we get data on the referrals that we send in, which ones are closed. So obviously our hope is to get that green, that's 18% got help. We'd love to see that as 100%, that every referral we make, we know they get help. But the barrier with this, as you'll see with that 69%, is not knowing which patients are able to have help or not. We do feel like a large portion of those do get help, and that's why we're not able to connect with them again. They no longer feel the need to take our follow-up phone call. But unfortunately, that is a gap that we are trying to close. And so that's what I would like to share. And then in addition to Medicaid, I'm actually going to transition over to Pam, who's going to talk about the SDOH program for commercial diabetic populations.
Thanks, Garrett. It's exciting to see all that's going on in our Dallas market in the Medicaid, watching that population grow, seeing the engagement of the physicians, knowing their population is getting this extra help, and seeing that the needs of the patients are being provided for. So thank you for sharing all of that today. As I talk about now our commercial population, this is a population in the Illinois, Chicago area. It is a PPO population. And although our care management programs always include an SDOH assessment, it's a part of what nursing has always done in psychosocial areas. We've tagged on to that, in this one particular, the diabetic population. And we're also going to look at race, ethnicity, and language. So this is our study. We're looking at A1c uncontrolled. That's how we're looking at this diabetic population. It also includes, as the HEDIS measure says, those patients who were not tested. So we're looking at race, language, and ethnicity also of that population. I'm going to share some data in a minute. Our program uses TransPerfect. That's our interpreter service. We want to make sure that as we identify language needs of this population, that we are prepared to care for them in the language that they prefer. As Garrett mentioned, we use the Healthy Leads SDOH screening. We use the same Finding Help as our resource for CBO referrals. As we care for those patients, we are doing a telephonic outreach. We, in the diabetic program, focus on scheduling testing to make sure we have an updated A1c, and that patients are enrolled in the diabetic education program where needed. In terms of A1c control, we looked at those patients actually that were uncontrolled in particular, and we had 943 patients that were not controlled. And of that, in the race, we found that the Black or African community was the population with poorest control. When we looked at ethnicity, we found that control was about 65% equal in both the Hispanic, Latino, or not Hispanic or Latino population. So there wasn't really a difference by ethnicity. When we looked at language, you can see we tracked an awful lot of language here, but we found that the Russian and the Polish population had the poorest control. But overwhelmingly, what we found was the population that did not report race, ethnicity, or language. That population actually had the poorest control. So where we started was on that population. We didn't know about those patients' race, language, ethnicity. We would collect it as we connected with patients. We would gather that information and we'd have it for our final analysis. After we reached out to that population, then we would circle around and care for the remainder of the population. We used a heat map. We just wanted a little bit more insight on who this population consisted of. We were able to look at, these are our diabetics uncontrolled. And so we looked at them by their A1c results, race, language, ethnicity. We looked at it by risk and opportunity score. That's part of our ACG model that we use for risk and opportunity. We can look at the pharmacy, zip code, where their PCPs were located. Good way to have a better insight visually on where your population lives. So we did our outreach, and this is what we found out. Initial reporting, this is just keep in mind, this has only been up and running for about a month. So initial reporting, we reached out to 21 members. 5 of those members opted out. 9 of the members we were unable to reach. We do follow the 3 contacts and send a letter for patients that we're unable to reach so that we feel that we've made enough an attempt. For members that opt out, we do go to the PCP. We try to make sure we always have accurate contact information, that the PCP tells the patient about our efforts to coordinate with them, and that those members ultimately will reach out to them again after the PCP talks to them and see if we can get those patients to opt into our program. SDOH screenings, we had 6 negative screenings. These patients had no needs at this time. We did have a patient who had a positive screening, and that was for housing, and we provided a resource through our Finding Help app. And then of these patients, the diabetic program enrollment occurred for 2 of the members. We looked at their A1Cs. We found that 2 patients moved from an 8.1 to an 8.4. That patient did agree to enroll in our program. The other one, once they were tested, their A1C was 61.1. They did not enroll in our diabetic program. And then the 3rd patient here that enrolled was A1C moved from 9.5 to 8.5, still an opportunity to work with that patient. So it's very preliminary study, but we're finding that we're pulling in not only the needs of SDOH, but the interest of race, language, and ethnicity in the populations that we care for. So we looked at all this reporting that Garrett's been doing. We looked at the reporting that we did in Illinois, and we came up with some common challenges. The health plans are requiring or requesting that we submit SDOH information through Z codes, with Z codes through the claims. But there is not always, the care isn't always being provided by the physician, and physicians are finding it a little bit burdensome. They have to accept the assessment from us, which we're always sharing information for them, but then they have to go through a process to be able to submit that claim. So there's a burden on them, and that's part of what Innovista focuses on, is partnering with these physicians to decrease their burden where we can provide care. The other thing that we recognize is there's a lot of SDOH data out there, and it's being collected by not just care management teams like Innovista providing, but through our hospitals and other care providers. And it would be nice to have a look at all SDOH throughout what's being collected by care teams to have a real comprehensive picture of the SDOH needs of the patient. We've brainstormed through some solutions. In our Dallas market for our Medicaid population, we've been implementing an HIE, and that's solving some of the puzzle because we're able to pull information from the HIE. We're also connecting the PCP with the HIE so that we can pull data from there. It's not all bidirectional yet, but we can find out more about the patient and share SDOH information that way. EMR integration, obviously, with more than just the EMR would be beneficial. EMR integration, even with platforms such as our care management platforms, so that we can produce standardized data. That standardized data is not all about pulling from the EMR. And then what we think about, but we're not quite sure yet, is what will the role of AI play in all of this? And we can't forget about that. How will it help us focus on the right patients and know more about the patients prior to doing an assessment? So in summary, we're very, very interested in the SDOH space. We know it impacts health. We know it impacts the cost of our associated populations. We know that our physicians are very interested in the SDOH space, but it is a burden for them to provide all the care. We know that they embrace the expanded team and they welcome the community health workers and are excited to see that care is provided to their patients. The community health workers have been an excellent resource. They really develop relationships with the patients. They're out there ready to be pulled into care teams, and they are excited about this work. NCQA and our health plans, they need to embrace this team approach. And by embracing the team approach, I think they need to have the ability to accept data from more than just the PCP's claim. And I think that's where we could look at standardized data, integration with care management platforms, and sending data in more than one way than just through a claim. The new measurement coming out, supposedly 2023, we'll see on SDOH screening and assessment and intervention, will challenge the PCPs. And we've certainly worked through some of those challenges. There may be more, but it will challenge them, and they're excited that we're there for them as their partner. Our technology, workflows, new workflows, how to communicate with practices, how to send them information, and the new relationships with the health plans that they see this need for a team approach and different ways to collect data. All of that is required to decrease the physician burden, because if we don't we need to look at that physician burden in order to engage the physicians in the work of SDOH and solve for the patient needs in that area. Are there any questions?
All righty. Hi, everybody. I want to pop back in. So as Garrett Schmidt first introduced me, my name is Laura Bingham. I am the marketing specialist at Innovista Health Solutions. And I am going to be reading out the question sent in. So we'll try and answer as many as we can here, but if we don't get to your question or you think of something after, do please reach out. So the first question here is actually for you, Garrett. When it says, when Garrett mentioned a decrease in number of times with connected patients, are you referring to face-to-face only? Does connected to patients include phone and text and or telehealth visits or check-ins?
Yeah, thanks. Thanks for asking that. So to clarify, it does refer to phone calls. And so it's just any time that we are talking with the patients. Yeah, so there's not the CHW team that we have, they aren't doing televisits per se, but yeah, it is phone calls in person. And so some of those are probably in person originally and maybe weren't able to connect or did connect via phone call later as a follow-up. But yes, that's what that meant. Thanks, Laura.
Absolutely. So we have another question here. This one's actually for Dr. Weiner. So what is the future for value-based care?
So I've been doing this work since about 2001-ish. I started with the CMS core measures, which was sort of the nascent part of value-based care. And every year I hear people saying it's just around the corner, and here we are 21 some odd years later. I think it will continue to grow. There continues to be pressure from both employers and the federal government to constrain costs and improve quality. The recent change of CMS to the REACH type ACOs appears to have some traction. And then many of the commercial payers are continuing to get into that value-based space. The dilemma with commercial payers is it's unclear who splits those savings. The employer wants a piece of it, the payer wants a piece of it, and certainly the providers want a piece of it. So it becomes a little bit more challenging in that space. But I do think that it will. The trajectory is clear. The pace, I'm not sure anyone could actually say.
Alrighty, thank you, Dr. Weiner. So this is a general question. So did you find there are certain helpful background requirements for clinical health workers, CHW, or community health workers, pardon?
Garrett, I toss that one to you since you're intimately involved.
I let Pam answer that one.
Oh, there we go. Hot potato. Okay.
So the community health worker also, it's a certification program. So, you know, to be honest, I don't know the requirements for that, but the community health workers that we've hired, we look for ability to form relationships first. They have to form those abilities over the phone. I find that the telephonic interview is a good place to start with finding whether they can develop a relationship over the phone. An interview needs to be more than just a question answer, but they need to be able to create a conversation. And so I'd say that that's the most critical thing. Then they need to really care for patients. They need to care for people and be patient. And those are the things that we look for first. If they're certified, then they have the basic understanding of the role and of healthcare. So we're looking for a relationship.
And I would.
I'm sorry. Go ahead, Garrett.
Sorry, I was just going to expand on that. That I would say that we have tried to look into people who didn't have the certification, and I think that's one of the first starts, though, just because when we looked into those and we did hire those that weren't certified as CHWs, it was harder for them to look past the rote questions that we have and to, like Pam said, to build that relationship. So I think that's a starting point, and then being able to build trust easily, like I was mentioning in the presentation, that this is the Medicaid population is one that doesn't trust easily, and they have a lot of mistrust around health and the needs here about, is someone trying to help me? Are they trying to look into something else? You know, maybe they're trying to look into my immigration status, and that's not the intent. And so, like Pam said, then the focus is being able to build that trust and build the relationship.
And for those of you interested in additional information about CHWs, I would refer you to Sinai Hospital, Chicago, Sinai Urban Institute. They've been in this space for, probably 15 or more years. If you need help in finding that website, let us know. We'll send you that link, and they could probably give you explicit details about some of these more detailed questions that you're asking.
Thank you. So another question. So are you, I'm imagining this is generally for Innovista, are you working with rural healthcare, and how does standard social determinants of health, or how are social determinants of health tracked in rural healthcare, in a rural healthcare setup?
Pam, you want to talk about our Central Texas market, which is pretty diverse, right?
Yes, Central Texas is very diverse. We have lots of rural patients right now. And in the Dallas community, I mean, it really covers a large area. It's not all inner city. So there's a lot of rural area too. It's been surprising the amount of resources that we do find through finding help for these patients in those rural areas. But our PCPs and then those offices, we've connected with churches. You have to be a little bit more willing to look beyond the app to find resources. Garrett, anything else about Dallas?
Yeah, I'd say that there's not as much in rural. I'd say that the more rural areas that we work in, it is a lot of it is education that we find is a huge piece of what is needed, of just not knowing what health preventative screenings that they need. And this, I mean, this goes beyond rural, so I guess I can't specifically speak to rural areas, but you know, one thing that CHWs find is that a lot of times they'll call someone, educate on, a lot of times the population doesn't know that they should be going to the PCP first, that they can go there for a common cold. There's a lot of, I think, misinformation or cultural things about going to the ER, that was just what they've always done. And so we see a lot of education gaps in their own healthcare, and why they would need those preventative screenings or why they should go to the PCP. And so I think that again, not specific to rural, but that's definitely something we see in the rural areas as well.
Thank you guys. So another question, love these questions. Thank you everybody, and do keep them coming. So we have, how long does the team work with patients?
So there isn't a necessarily a set amount of time that the CHW will work with someone. I mean, as long as someone has a need and they want that CHW support, we will continue to support them. A lot of times, I guess I say that because there's no one that really wants to forever have a CHW. Usually as they're going, we try to show them, find help is actually a tool that anyone can use, and it is very, as long as you start to get an idea of how it works, it's pretty intuitive. And so the CHWs would try to help get people more self-sufficient, but will work with them as long as they're wanting or needing support from a CHW.
In our diabetic programs, we develop goals with the patients around their disease process, what they'd like to work on in order to lower their A1c. So those programs are very individualized, and the length can vary depending on the goals of that individual person.
Absolutely, thank you. Okay. Let's see. So I asked this question, so I believe this is the person who asked the previous question, or it looks like, so I asked this question because I know your data showed an area of struggle was confirming if patients were connected to referrals made.
Sorry, what was the question?
So this was related to the previous question that I just asked. So they asked because they know that our data showed that an area of struggle was confirming if patients were actually connected with the referrals that were made.
Yeah, so I guess that is, just to speak to that the CHWs are willing to work with people as long as they need help, but we do find that after referring, it is a struggle to get them to follow up. And so our hope with that obviously is that they feel like they no longer need the support, they feel like they got the help, and so they don't answer. But unfortunately, that is a a gap that we don't know if they just never went, they never received the help, or if it just wasn't reported. So yeah, that is yeah, that is a correct statement.
So we have another, thank you, Garrett. We have another question about community health workers. So what are the qualifications or certifications that a community health worker has? And then what is an ideal professional to perform as a community health worker?
So community healthcare workers aren't necessarily professionals at all. And I would refer the participant to the Sinai Urban Health Institute website to really look at the details for how they choose and how they train their community healthcare workers. We're sort of at the far end of that, where we identify people who've already been certified and see if they fit in our system. But I think the question really is a little bit more upstream, so I would refer them to that website.
Many states have community health worker organizations. You can also look up your state and see if they have an organization, and then often they will post those within that site, as well as the schools that provide certification in your area.
I think we have also seen that those that are going into social work sometimes get a CHW certification, and it's kind of a, I guess, a stepping stone for their social work career. But I think to Dr. Wayner's point, it's not necessarily a professional level at, as a CHW.
Thank you. So another question. So how do you evaluate or grade the capabilities of CBOs?
That is an excellent question. I think that one thing that we tried to look at especially when we were trying to build our CBO collaboration, was the looking at which needs the community has, which ones were we seeing in our population, and then finding those that were engaged, those that were responsive, that they give us more feedback on whether someone got help, and then trying to partner with those organizations. I think outside of those that we're in a collaboration with, we would definitely look at those that are more engaged and communicative, because we sometimes have a hard time getting follow-up from an organization. We'll let them know that we sent someone over, and that we'll not hear back from them either. So there's a two-part of, we can either hear from the CBO or the patient on if they got help. And so we do try to look at, this CBO was not as responsive, not as engaged. We might try to find a different organization to refer to in the future. And that is actually a part of what we do in Find Help. We're able to make notes and have favorites lists, and let our team know that there might be an organization that's either more responsive or less responsive, and then to work from there.
Thank you. So I believe we have time for one more question. So how is care coordination done related to a social determinants of health application?
Garrett, do you want to talk a little bit about how finding help works?
Yeah. So Find Help, just touched on it briefly, but essentially Find Help has all the categories laid out. I think there's 8 different categories, and then it has subcategories from there. Obviously housing, food, education, a lot of the different categories that we mentioned today. And so you're able to look through that based on zip code. You can filter out different criteria that you might have. You could filter out eligibility based on income, whether income's not, whether you don't want to take that into account. There's different things you can try to narrow organizations down based on whether you're looking for completely free services or just reduced cost services. So you're able to filter and search for a lot of different organizations. From there, you can make direct referrals. You can also just send the information to a patient, but basically referrals are made. We take note of that. We put it in our care management system, as well as taking notes and find help, and then try to obviously make note to follow up from there as well. And so the CHW would then look back, see who was referred or see who had needs, and then see what we can do to try to help close those gaps. And a lot of times in the initial conversation, trying to make plans for when the next follow-up could happen, and goals as well for how we can get them to the different CBOs that they need. Hopefully that answers the question.
Thank you, Garrett.
Thank you, everybody. So this is all the time that we have for questions right now. If your question was not answered, we will be putting up some contact information at the end of this presentation. But I just want to thank everybody for the questions. They were really fantastic. I do want to say something before Garrett starts here. So you'll notice a discrepancy between the style of our slides and the style of our booths. We are currently in the process of a rebrand. That does not mean anything. Innovista itself is not changing. We're providing the same service, the level of service. We're just giving ourselves a little facelift. So with that, I will hand it off to Garrett. Thank you.
All right, so many Garretts to keep track of. Yeah, thank you guys so much. This is such a wonderful presentation, and I know I got a lot out of it. I hope that you all did as well. If you have a last-minute question that's still burning, go ahead and submit it. We're going to get to as many questions, obviously we did as we could today, but we're going to go ahead and answer all the questions that come in via email. So go ahead and ask your question if you still have one. Again, thank you so much to our speakers. You guys were great. This was very engaging. And as Laura mentioned on the slide there, actually, Pam, can I have you go back real quick? If you head over to bbcexhibithall.com, you will be able to visit the Innovista Health Solutions exhibit booth. It's a virtual exposition booth where you can interact with their team and learn more about what they're doing. And there's a lot of fun and cool resources there. It's also where the recording of the webinar will be housed indefinitely in our library there. But I'm speaking of that, I'm going to be sending out later on today, as late as this evening, perhaps a link to the recording, as well as a link to where you can download the slides. So you should be able to review it, and we hope that you do. And then lastly, if you'd like to get a hold of any of our speakers to ask any more questions or to reach out to the Innovista team, Pam, I'm going to have you put up that last slide with their contact information there, and you should be able to reach out to them, or feel free to reach out to me as well, and I'm happy to facilitate an introduction or put you in touch. Thank you all again for attending. I know there's a lot vying for your time. It means a lot that you decided to spend the afternoon with us. Hope you have a wonderful rest of your week. Stay safe and healthy. Bye-bye.
Thank you.
Thanks, everybody.